Hi there, and welcome to my infant feeding free webinar. So, this is mostly geared for parents, but I think will also be very beneficial for professionals as well. So, whoever you are, welcome, and thanks for joining. I'm not exactly sure how long it'll run. Maybe about a 30 minutes, could be 45 minutes. I'm not positive. If you have any specific questions, since this is not going to be alive right now, at least, um, you can always message us or send us a DM at our at Foodology Feeding on Instagram or, on any of the social media platforms that we are on. So, I just again want to welcome you. Try to keep your questions to the presentation only if you do send us questions, because we can't answer any specific questions about your child unless we have done an evaluation with you. So, we won't be able to answer specifics, but if you did have a question about something we mentioned on one of the slides, then you could definitely please let us know. Feel free to get a snack. Pen and notepad is a definite, because you might want to take some notes about what I am sharing here today. Okay, so really briefly, who are we? What is Foodology Feeding? I'm Christine. I am the owner and founder of Foodology Feeding Therapy. I'm a mom of a child who had a lot of issues with food. So from literally day one that he was born, we were struggling. And I didn't honestly know a ton about it before I had a child. And that's sort of why I became so passionate about it, because I realized that I didn't have a lot of good information, and there was a lot of conflicting information online, and there just like wasn't a lot of support in general. So, being a speech pathologist by trade, I decided to just take a deep dive in, and I took a ton of courses literally with my infant like in my arms, just online learning course after course after course. Um, and it helped totally change my feeding relationship with my son. But, I still see the struggles that continue to this day. So it's not like the journey was over, or, I'm still learning and growing. But, I've learned so much. And if I had to go back and do it all, again, if I had another child and they needed it, I would do things differently for sure. So, I've learned a lot along the way, but now that I have so much knowledge, if I were to start fresh, um, I would probably do things in a different order. So, really, I'm trying to save people a lot of struggle and tears and heartache. So hopefully this presentation will be really beneficial. So we have at my clinic an extensive amount of training in feeding. And I do say extensive because feeding is so complex and specific. And if feeding at different age groups is also very, very different. So we have tons and tons and tons of training on all of the different age groups for children. Now, some of us that work here have more training in specific age groups than others. I probably have the most training for all of the different age groups, but everyone kind of has their area of specialty and expertise. But even 0 to 6 months is, so much changes with feeding in 0 to 6 months. And there's so many milestones, and we'll go over that. This is really for 0 to 6 months, this presentation. So if you have older kids, feel free to check out our other offerings at foodologyfeeding.com. We have lots of courses, some free webinars and trainings and things like that. So there's lots of things that, you can learn about. So definitely check us out. We offer lots of free help and information, as well as paid offerings as well. So our mission is we're here to empower and educate, help you to take action because there is action you have to take. Not every kid just comes out and is like the best eater. Of course, that does happen. But when it doesn't, there are some certain specific steps you have to take, but we really want you to be empowered and educated yourself so that you can advocate best for your child. Because, the worst thing to assume is that just because you take your child to a professional or a doctor, that they know everything about what's best for your child. So the more you know and the more you can trust your own intuition, you'll be able to quickly and easily, hopefully, solve your problems, because you internally have like your own compass and direction. But if you don't have that education, you're just going to be at the mercy of listening to whatever person you go to. And if that person actually doesn't have good training or doesn't know exactly what to do in that situation, you're not going to have the best resources, right? So this is for you to learn and just know about these things yourself. Okay, so let's just dive right in. So red flags that you need to know about. Okay, and there is quite a bunch here. Made a pretty comprehensive list. So if you're seeing these would lead me to think that your child is having some sort of a problem. Okay, now a lot of these things that you probably know, but there should be a few new ones on here. Now, of course, if your baby isn't latching properly, and this could be breast or bottle feeding, so you might see, spilling or leaking. Another thing is hearing the clicking sounds. That is indicative of a poor latch. Now, if baby is vomiting during feedings, spitting up a lot, those are also indicative of problems. Of course, babies do spit up, right? But excessive spitting up or spitting up accompanied with crying and arching and discomfort is a red flag. Any coughing, gagging, or choking during breast or bottle feedings, another red flag. Baby refusing breast or bottle, that's bottle aversion, and that does happen. And that's actually one of the things that we actually will teach parents how to remediate, because at some point, if feeding does not go well for a period of time, babies can start to refuse to eat. And it's really a myth that if they're hungry enough, they will eat. That is just absolutely not true. Otherwise, we wouldn't have babies with feeding tubes. Okay, well, that's not 100% true. If there's something physiological wrong with their swallowing reflex or whatever, they could have a feeding tube as well. But we have had kids go onto tubes because they refused to eat. And that process became so stressful that the only solution became to do the tube. Okay, so it definitely can happen. That is a myth. A colicky baby. Now, this I find it's almost something in society that's so commonplace that people just say like, oh, you just have a colicky baby, like as if there's nothing that can be done about that or is alarming about that. But colicky baby actually is relating to feeding issues and discomfort, specifically in their bellies and guts with feeding. So something that needs to be looked at if you are being told that your baby is very colicky and you're finding they're crying a lot, even outside of feeding times, they're just constantly seem uncomfortable. Okay, that's not typical. That's not normal. So, some people might say that it's normal. It's just a part of being a mom, right? But that's not necessarily true, especially when it's accompanied by some of these other red flags, right? Anytime you are feeding, though, if you feel like, oh, they just seem uncomfortable, they seem like they're in pain, right? So that means they might be crying, arching their back. They might be even hard to hold. They might become very wiggly. And this could be during or right after feeding as well. So a lot of those things that I just described are actually signs of reflux. So if your baby has been diagnosed with reflux or GERD, GERD, it's just kind of an acronym for reflux. But if your baby's been diagnosed with that, or you see any of those things happening, that is essentially reflux. Okay. Now, sometimes babies will have a failure to gain weight or will gain weight very, very slowly. So we find that a lot of people that come to our clinic, they have been actually, they've come because of concern of poor weight gain. And, every time they go for a weight check at the pediatrician, they're falling off, and their percentile is going lower and lower and lower. Now, even if you have all of those issues, sometimes baby still gains weight well. And doctors will say, well, I'm not concerned because they're still gaining weight. That is not a good thing to say. So even if they are gaining weight and they still have these issues, there's still something that we have to fix, because weight is not the only factor, right? So, but there is a possibility, again, that because they are not eating enough, they don't want to eat enough, they're actually not eating enough to gain enough weight, right? So that's a very, very probable and possible problem that you would encounter. Now, in very small babies, you might not see ear infections. You may, but ear infections, recurring ear infections, are red flags for feeding dysfunction, actually, believe it or not. And the reason for that is the placement of the eustachian tube. Now, as you grow, the eustachian tube, you kind of starts out flat, and as you grow, it's supposed to become more and more vertical. But I will tell you that in babies that have feeding issues, um, even very young babies, compared to typical children without feeding issues, the ones with feeding issues typically have more ear infections, even from as a baby, in the comparison, like if you had to compare those two groups, right? Now, another thing is you might be classified as, oh, you just have a baby who's hard to feed. Now, if you find feeding times challenging for any reason, I would say it's something to look at, because unless it's totally on you, like you don't like breastfeeding, because you don't like that feeling for some reason, or if you're formula feeding, you hate feeding times because you hate getting the bottle ready. I don't mean that. I mean, every time you go to feed baby, you dread it because they're going to cry, because they're going to start falling asleep, which is another one of our red flags, falling asleep while eating. But that there's some sort of a challenge between you and the baby with feeding. And that really weighs heavily on a mother's brain, because, honestly, we feel like, hey, this is like our main job, right? To make sure baby's eating. And when they're not eating well, you even subconsciously will put that back onto you as that you're not doing a good job or you're doing something wrong. And that might not be the case. Of course, there may be some things we can do or fix to make it a little bit easier, but it might just be some oral dysfunction, right? So those are really important to note. Also, extended feeding time. So taking over 30 minutes for a feeding. Now, I'm not talking about like the first day or two of life where they're constantly, everything's a little bit off and everyone's learning. But, when you're, at week 3, 4, 5, we don't want one feeding to be lasting too long. It's not the norm. They should basically be around 15 minutes or so. Now, that's because they do feed so often. So babies eat about every 2 hours, and sometimes a little bit sooner when they're very new infants. But we don't want them. So if it takes you, like we've had moms that come in and they say, our feedings take 50 minutes to an hour. Okay, so they almost don't even have like a break. There's that feeding, pooping, sleeping, feeding, pooping, sleeping. It kind of throws off the whole routine if feeding is starting to take a big chunk of time, right? It throws everything off. So feeding over 30 minutes is a red flag. Also, so this kind of goes with that, but requiring multiple short feedings throughout the day. So eating every hour. I've had parents tell me he wants to eat every 30 minutes, right? Being hungry constantly is a sign that they're not getting enough in the one meal. And that's actually what happened personally to me. He was never hungry. It was never full enough, I should say. He was always, always hungry. And that is because he was he couldn't take enough in. He was trying and he wasn't getting enough. So, feedings, excessively short feedings, like popping on and off bottle or breast constantly, because they just can't take a lot at a time. And sometimes that's why parents will say, oh, it takes like an hour to finish a bottle or for me to feel like the breast is drained. It's because they have these little micro feedings that they like can only get a little bit in, a little bit in, a little bit in, right? Also, red flag there. Like I said, falling asleep during feedings. Also, volume limited feedings. So if you notice, this is hard for breastfeeding moms, but for bottle feeding moms, oh, they always stop when it gets to 1 ounce, or they always stop at 2.5 ounces, whatever it is. But it's almost like a consistent, like, well, I know once we hit this, they're going to stop. That is also a red flag as well. And that does happen quite often. We do see that there is like a volume limit, and that's telling. That's usually actually a pain threshold, that when they get to that limit, it's like, oh, wait, that's painful, and now I'm going to stop. So that's usually what that limit actually means. Okay. Now, if your baby is 6 months old, and I said this is a 0 to 6 month old webinar because some parents start before months of age, right? We hear sometimes 4 months, which is outdated advice, I would say. I wouldn't recommend doing my cereals before the 4 month mark. But if you notice with puree feedings that they're gagging or becoming very fussy, let's see, not accepting any type of cup by 10 months old would be a red flag. I know I said 0 to 6, but I'm going to throw that in there. And not accepting purees after 10 months old can also be a red flag. All right. So I know we went over lots and lots of things. That's why I said to take some notes. Okay, so let's just go into some natural instincts that babies have. What's normal, what's abnormal. And you need to know what's abnormal and what's normal, because how are you going to tell if your baby is doing something that they should or shouldn't be doing, right? Right. Instead of just guessing, like, I don't know, I guess that's normal. I guess that's what babies do, right? So let's start here in birth to 6 months, all the way here with our little cute little baby with his fingers in his mouth. Okay. So at this month, eating is totally reflexive. There's nothing that they are actually doing that's not automatic at this point. So, when something touches the top of baby's mouth, they should open and begin to suck. They should be able to coordinate sucking, swallowing, and breathing all as one motion from day one. Okay, so if they're struggling with that, so if they have to actually stop feeding to take a breath, that would be discoordination. We don't want to see that. Okay. Bringing hand to mouth, that's going to open the mouth in preparation to start sucking. Even holding objects and bringing them to their mouth, that's all good. So we want to see that from birth to even up to 6 months, or sometimes 4 months, right? Now, from 4 to 6 months, right here, let's see. So our eating reflexes, they tend to fade. Okay, so they start gaining voluntary control over eating, which is great. So they begin to sit up with support, and then at some point, not even any support, unaided. And that's what you want to see. That's like a good sign that they're ready to start solids, is that they're sitting up unassisted by themselves. They're not flopping over. They have good head control, good trunk control, right? Core strength. If you approach them with a spoon, they'll open their mouth automatically. They can move food from side to side in their mouth, and teeth might start to show up a little bit early. Sometimes it does. Most times around 8 months old is when a first tooth will erupt. Okay. So between 6 and 9 months old, that's when they'll start to develop that pincer grasp where they can pick up like the little puffs and things like little small pieces of food with their fingers. They should definitely be able to sit up without any support at this point, and they should be able to chew soft lumps of food and keep most foods in their mouth. They can close their lips on the spoon. So when you put the spoon in, they'll close their lips around it. That again, these are 6 to 9 months. They should start drinking from a straw and an open cup also around 6 months of age. Now, 9 to 12, they should be able to bite into harder foods, especially once their teeth have erupted. But their jaws are very strong as well. Now, with biting into harder foods, especially with baby-led weaning, as soon as they can bite off pieces of that food, it will become not safe because a lot of times baby-led weaning, you're giving them things like carrot sticks, things that are hard, right? But if they can bite off a piece of that carrot, then that hard carrot, I should say, not a soft carrot, different, but a hard raw carrot, it becomes not safe anymore, right? So you want to take that away. Again, raw carrots are fine when they're like 6 months old and they're just kind of mouthing and exploring the foods. Usually around 8 months old, where their jaw becomes stronger, they have teeth that they'll be able to actually bite off pieces. And that's where I usually draw the line and I say, okay, take that out. Okay. Now, around 14 months, I know I'm going beyond here, but that's when they do have a little bit more autonomy and they might want to do things a specific way. Like they might start wanting to feed themselves and not have you feed them. They might want to pick up, the food on their own with their fingers. They don't want, they don't want help. They want to be like a big boy or girl and do it themselves. So that's typical for spoon feeding. Okay. Now, our body's first priority. Now, you might be thinking that you might know this. Now, I'll tell you, the first priority is breathing. We have to be able to breathe. And for infants, we always talk about suck, swallow, breathe sequence. So they suck, they swallow the liquid, they take a breath. Okay. But without unlatching, it all happens while on the bottle. Okay. So our biological priority is breathing. So if they are having trouble coordinating this sequence, they will stop eating so that they can take a breath. Okay, so it's rhythmical. They're breathing through their nose. Okay, they should not be breathing through their mouth for this process. It's the first pattern that they are learning, and it's the most important one, and breathing will always take priority over feeding, right? So you probably guessed that one, but this sequence is very important for infants. So if they're not coordinating this, you're going to again look for coughing, choking. They might do like a bad pacing. So they might suck, swallow, then breathe, right? And they might have some aversions. So you might see that as well. But now, do you know the body's second priority? Okay. Okay, this is exactly what I just talked about, the sucking, the swallowing, and the breathing. Okay, so this just explains it in a little bit more detail. Sorry, I forgot about this slide. But nothing we didn't really already say here. Now, our body's second priority, right? Now, you might be able to take a guess based on what you're seeing here, but it is not food, actually. Second is positioning. Positioning. So for this one, I want you to grab a snack. Okay, so now, can you eat while extending your feet into the air? Yes, you can, but it is much harder. So positioning very important. Do you see this blue line here on this high chair? Now, there is a reason for that. We want stable feet. And you might be thinking, yeah, but I have an infant. Well, sometimes foot stability can also work really well for infants. So if their feet are dangling, what you can do is you can get a pillow, or I even used to use my hands depending on where we were. But I would just take my hands and actually, hold on, let me grab my baby here. So, just kind of grabbing, the ends here. So, I would actually feel him almost trying to get that sense of stability at his feet. And I would feel him kind of pushing back on it. So, a pillow right at baby's feet is good to give them some stability. Or, again, I used my hands as like a quick, easy backup, especially if we were out and about, but just something so that their legs aren't hanging. That will make it feeding a little bit harder. So now you can try this yourself. You can eat food with your feet up off the ground in front of you in the air. Now, can you eat? Yeah, but you know why? Because you're using your trunk support. You have good trunk support. Now, a lot of our babies do not have great trunk support yet, right? Especially if there's any sort of delays or any tone issues, low tone, or any sort of syndromes that might contribute to issues with tone and stability here, muscle strength. um, so for those kids, it's going to be even harder, and stability is going to be even more important than it already is. um, our body is always seeking postural stability. So no matter what you're doing, you're constantly, you're not conscious of this process, but this is what your parasympathetic nervous system is doing. It's working in the background while you are conscious. It's working on things like breathing and digestion and postural stability. So it automatically is writing you so that you know where your body is in space. Now, if there's any sort of difficulty with that process, or it's going to make feeding more difficult for sure. So baby needs to feel comfortable and secure in their positioning. That will definitely make feedings easier, whether you have an infant or a toddler sitting up in a high chair. Um, so they should feel very secure against mom's body, ideally facing each other, belly button to belly button, right? So that is where you're going to get the most secure fit. Okay. So the more of the baby actually touching your body, the more secure and stable they will be. And again, ideally, if you can, instead of these feet dangling, you're going to use something at the feet, whether it be the end of the couch, or, if you should be sitting in a nice stable chair. Or again, I always used my hands as a last resort if I didn't have anything like that. Okay. Um, And again, sitting infants and children should have feet firmly planted. Now, I'll tell you, 95% of high chairs don't have that capacity. So, yes, you can buy them. Yes, they do tend to be more expensive. I'd still recommend them, even though they're more expensive, especially because they grow with the child usually, right? But also because it's really what they need. And I really wish that, high chair company would take this into consideration. Um, Now, when you have stability and you have good coordination of your breath, you are going to have a much easier time feeding your baby. Okay. So, again, we want something with stability here. Okay. Very important. So, this little bar is important. Now, I don't even love this bar because it can't even hold all of baby's foot at the same time. But is it better than just dangling? Yes, but it's still not ideal. Okay. Now, this is actually my son in his chair. Now, I want you to see that his knees are at a 90-degree angle. His hips are at a 90-degree angle, and so are the ankles. So this is very important. We want to keep this as our constant, okay? Now, reason number 3 are physical restrictions, okay? Why baby is struggling. Now, these are types of ties that you will commonly see. Now, an anterior tie is the most common. It is not the most common. It's the easiest to see, okay? Because it's attached right at the tip. Anterior means the front. Okay, posterior means the back. These are the most common we see, but they're the hardest that I find, like more layman's, like doctors and pediatricians, things like that, to actually diagnose because they're harder to see, right? Because you do have to lift up the tongue. They're further back, okay? And this is a lip tie. So that's when the connective tissue comes down to the gum line here. So this is a very thick lip tie. Now, there's also, you can't see it here because these are harder to see, but a cheek tie as well, or a buckle tie is another term for it, but it means cheek tie. Okay, so that's when the cheek connects to the bony ridge up at the gum. Okay, so sometimes kids will have all of these together. It is very possible. Very common, we see lip and posterior ties together. That's probably the most common that we see in our practice. Now, this is present from prior to birth. So this occurs in the womb during development. And what it is connective tissue that just doesn't recede all the way like it's supposed to. Okay, so what happens when you have this is that it's called a tongue tie, right? Or a lip tie. It's somewhat pulled, it's somewhat restricted. So it doesn't allow full range of full range of movement to occur. And it makes life difficult. In fact, it makes it hellish for many, not all, but many. For me, it did. Okay, so again, the signs and symptoms that I talked about earlier, many of them will overlap with these physical restrictions. So if baby's struggling to latch on to breast or bottle, okay, you might actually see the top upper lip tucked in, okay? It should be flanged out. Let me just, I don't know if it was in that other photo. Okay, so this top lip should be flanged out, not tucked in, okay? Whoops. Okay, so flanged out. Any clicking sounds on breast or bottle, that poor coordination, suck, swallow, and breathe, colicness, gassiness, any sort of extended breastfeeding or bottle feeding times, painful feeding, that's nipple pain during breastfeedings. Now, we will talk about that more as well. Now, you might find that, baby does stick their tongue out, so they must not have a tongue tie. But again, with these posterior ties, they might be able to stick their tongue out, but they might be restricted in how far it can go. And again, remember, we need the tongue to actually come back. The back of the tongue has to be able to work almost independently of the front tip of the tongue because there's 8 different muscles in the tongue. So the different muscles have different functions. So the back of the tongue is actually can be, raised, and the front tip of the tongue could be down. Those are things that are a little bit more complex, can affect speech later on as well, especially like the R sound. A lot of kids with the R sound actually have ties because they have trouble bringing that tongue back and lifting the sides of that tongue up, right? So those are different muscles involved in that. And that restriction actually prevents that full movement from occurring really easily. A lot of our babies with ties will have failure to thrive or that poor weight gain, like we had said. Um, and some of our older kids, they actually have more cavities because the tongue is not able to get down into the pockets to clean. One of the jobs of the tongue is actually to clean the teeth off. And, when you don't have good movement there, a lot of plaque gets hidden and stuck in the back here and produces cavities, in fact. Reflux is pretty common in tongue-tied babies as well. And it also causes structural issues. So the palate will actually become high and narrow when it's supposed to actually hold the shape of the tongue. Now, what is supposed to happen. So as you can see, there's a lot of things that can actually occur later in life as a result of these ties as well, including sleep issues, right? And I'm going to show you why that in a minute. So your tongue is supposed to be up here at the very top of your mouth. So tongue up behind, basically behind where these front teeth are on the bumpy ridges here. Now, one of the reasons is, and your tongue is supposed to remain up there, yes, even while you're sleeping. So your tongue is a natural palate expander. Your tongue actually holds the shape of your palate as it's supposed to be. Now, if your tongue is restricted and it's pulled down and it rests low in your mouth, down here by the bottom teeth instead, what happens is the palate, instead of staying nice and flat and rounded like this, it will start growing like this and become narrow and high. And as you can see, actually, the mouth is wider and larger when you have this nice flat shape. So you actually have less space in your mouth for teeth to grow. And a lot of people will need to have teeth pulled. And that is one, they'll have crowding and need braces, right? So that's one of the reasons that we want that tongue up at the palate. And very important for sleep, right? So if your tongue falls, okay, so if your tongue is up here, it's actually up and out of the airway, because what's right behind your tongue is the trachea, your airway. Okay, so where you're breathing. So if your tongue is up here, the tongue where it's supposed to be, it's out of your airway. Now, if your tongue stays low in your mouth, it actually ends up falling back into the airway with gravity. So when it falls back into the airway, it makes the airway narrower. And that's why sometimes you'll hear breathing. You could like audible breathing or snoring even. And a lot of people think, oh, the baby, he's so cute. He's sleeping with his mouth open and he's snoring. That's not cute. Okay, that's a problem. So we don't want to see mouths open. We don't want to see low tongue in the mouth. We want tongue up there while sleeping. It's very, very, very important. In fact, I highly recommend, if you're like, hey, I think we have some of these problems in our household, definitely check out the book Breath by James Nestor. It explains a ton about this. It's an excellent, excellent book if you have not read it. And it's not for professionals necessarily. It's he's a journalist who did research in this, and it's very interesting. Okay, so why else is baby struggling with feeding? And it's the suck. So a lot of times compensations will develop and they'll overuse their lip or cheek muscles. They might compensate by biting down on the nipple instead of sucking to try to get liquid to come out, and they start chomping. Okay, and yeah, they can do that on the breast too. And yeah, that can be very uncomfortable and hurt and make moms not want to breastfeed anymore, right? So the suck is very, it's very important to have a good coordinated suck. What we want to see is like a wave-like motion with the tongue. That should be what's happening. And a lot of times when I put my finger in a baby's mouth to feel that suck, because again, infants, it's a reflex. It's a reflex at that point. So when I put my finger up there at the palate, the baby should start sucking automatically. And when I feel, a lot of times, I feel like a little, like we call it like tongue humping, which is like, okay, it's just trying its hardest, or I'll actually feel like chomping and I know that they're not sucking. Like they're not even, there's no suck there, right? So that's a problem. So sucking can be actually caused by the compensation of not having good full mobility of the tongue because of the tongue tie, right? And don't forget, they've been practicing swallowing in utero for months. Since this is developed, these ties develop around 12 weeks gestation. So that's a long time, right? That's many months of swallowing incorrectly. So even if you do get that corrected, you still need the oral motor therapy. You still need the body work to correct that that new pattern that has to develop. Like you have to kind of teach that, because they've been compensating for this tongue restriction by basically like thrusting their tongue around, trying to get something to happen. And they develop these compensations, right, because of it. So super important. Now the pain. We talked about this myth before. If they're hungry, they will eat. But pain will trump hunger, right? We did actually discuss this already, but food aversion, bottle aversion, it's usually, it's trumped by our stress, pain, and any fear that we have, right? So if we're fearful that we're going to do something that's causing us pain, we're not going to want to eat. So, now, why would babies that, have ties or whatever, ties or reflux, not want to eat? Well, one, it's hard. It's really hard to do. It might be stressing mom out. So every time mom puts me on, she gets all anxious, right? Babies feel that. Baby gets all anxious. No one's enjoying themselves, right? It becomes of like almost like a fearful like experience, like, oh no, it's time to do this thing again, right? If you're dreading it, chances are baby is also dreading it as well. It's stressful for you, it's stressful for them. Um, Even if you're wincing in pain and you're like, no, 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 I'm going to fight through it, that tenses you up. They're going to get a little tense too, right? And if they're feeling any pain, any reflux, now reflux can be caused by taking in extra air because they're not doing their suck, swallow, breathe well. They don't have good lip seal. Anytime you take in extra air, they have little tiny bellies. It's going to cause a lot of discomfort, okay? Think of it as like a hot stove. If every time you ate, you took in this air and all of a sudden you got sharp pains in your belly, it's a hot stove, right? You touch it once and you're like, oh, I'm not going to do that again, right? So think about how many times babies eat every day, every feeding. They start taking in air. Every feeding, they get these pains. They're going to start to associate feeding with pain and not want to do that thing anymore, right? So it is totally a myth that if they are hungry, they will eat, right? So, the pain, whether it be reflux, it usually is related to reflux or some sort of a sensitivity to something in the milk or the formula. You're risking that they're going to get failure to thrive, that, we don't want them to get to that point where we're talking about feeding tubes. We want to fix these issues immediately as soon as they come up. Okay. So we don't want to stress them out. If they're uncomfortable, we've got to fix what's causing them discomfort is really the bottom line. Because all we're going to do is if we try to push them past that and make them feed anyway, even though they're uncomfortable, we're going to start making them hate feeding and not want to do it anymore, right? Now, let's see. Okay, so other pain reasons could be, mouth ulcers. I'd say it's more uncommon. Reflux, like we said, milk protein allergies, very common. Chronic constipation, right? but gut issues, like things that can cause that pain. Um, it doesn't have to be ties that causes pain, but it's I'd say a more common one, but it's not always the reason. Okay, now sensory is another reason that kids struggle with feeding, right? Sensory processing disorder. Okay, so as you can see, there's this whole web here. Now, the most common ones that you are going to note are, you know, kids that like crave like being spun around, thrown upside down, right? Those are sensory like seekers here. Okay. That's like a very common one. But see, as you can see, there's other branches to this tree here. Sensory discrimination disorder, that might be you're getting into a little bit more details here, I would say. Most of this is not going to be super, super relevant to you, especially until you start eating with textures and there is that tactile and they're playing with the food, right? A lot of this won't apply necessarily to infants, but it's going to be things like, so our picky eaters sometimes their visual sensory system is so overwhelmed, um and it's a little over responsive, so they might see a lot of stuff on the plate and get like freaked out, right? um they might, so some of our kids that stuff food in their mouth and they take big, big bites, those kids are under responsive often, and they need to feel more in their mouth to almost feel like where there's food in their mouth, right? So sometimes sensory issues like this can cause feeding. Now, I will tell you, everyone has some over and some under responsive in some areas, and it changes throughout our life. It changes based on the day. Not every day our sensory system is exactly the same, right? I can tell you, and I'm sure you know, there's adults that don't like to eat, raw fish because they don't like the texture, or they don't like touching things like worms and dirt because they don't like the texture, or they can't even. I have a friend that she can't look at a certain type of flowers with holes, and it freaks her out, right? Everyone's got their own sensory stuff. Everyone. So, I don't want you to think if your child has something with sensory that there is something really wrong with them. Everyone has got a little bit of sensory stuff, but it's important to note that sensory is a component of feeding. It just is. You can't separate the sensory system from your motor system, and every food is a sensory experience. Every food has a different texture. Every food has different colors and flavors, right? So it's just it's a part of the whole deal, is what I'm trying to explain. You don't have to go crazy memorizing this. It's not going to help you at all. It's just really important to know that the sensory system is a big part of feeding, okay? Um, so what do we do now? Okay, well, the very first thing is, like I said at the beginning, is just to advocate and educate yourself. You are your child's best advocate. No one else is going to care about your child as much as you do. It's a fact. So, like, we just got to get over that, right? So, it's not to say that, your pediatrician won't advocate for you, but sometimes they might not know, or they might not have learned about this stuff yet. But watching this, educating yourself about this is really, really important. Okay. And whoever you go to, you might go to an SLP, you might go to a dietitian, an OT, right? Ask them about their training. How many courses have they taken in this age group or with this type of issue? Have you ever had kids that had the same diagnosis as my child, and how did that go? Like, what did that look like? Are they trained by a third party? So for example, did they actually listen to the course presenter, or did they just have like someone like tell them, in the office, like, oh yeah, make sure you do this, this, and this, right? That's a very different training than going to like a 3-day training and learning from the person who teaches the course and taking notes and passing a test in it and things like that, right? So did you just read about it, or, did you take like a 4-day course, Um, Now, many doctors don't know how to assess tongue movement and other restrictions. Lactation issues, food aversions. A lot of them will say wait and see. A lot of them say they'll probably grow out of it. And we know there's so much data. Everyone knows that early intervention is the best. Nip it in the bud. Don't let it get out of hand, right? There's so much evidence for that, yet we always hear parents that come to us and their kids are 8, 11, 15. They kept saying they'd grow out of it. They kept saying it wasn't a problem, but here I am, right? So, of course, it's always best to address things sooner than later, right? There's always an optimal time to do that, to do these things. And sometimes it's not the best time. Like, I wouldn't necessarily recommend that on day 3 of a child's life, that if you see a tongue tie, that you go and get it released. It might not be the best course of action for several reasons, but that's why it's important to educate yourself and advocate and go to professionals that have this training and experience, because it's invaluable and it's super important to have. Um, you know, and if something doesn't feel right, if something's telling you something and it doesn't resonate with you, it doesn't feel right, then you got to go with your gut, right? Even if it's me, even if what I'm saying doesn't resonate, and you're like, no, I don't think it's that. I think there's something else. I think there's something else. If that's what your gut's telling you, I feel like you got to go with your gut, right? Um, but the more you educate yourself, the clearer that message internally, I think, will be for you, and it'll be easier to discern that, right? So, we'll just do a quick case study. So, a 4-month-old, difficulty breastfeeding, spitting up, failure to thrive, low weight, taking a lot of breaks, starting to refuse the bottle, and very extended meal times. Oh, close to what I said before, right? Around 15 minutes. Okay, so at the evaluation, we saw a lot of red flags. Poor suck, poor mastication, poor mastication. So that's chewing. Again, it's a reflex. So I'm looking for, if I put my finger there, are they going to start chomping on it? Difficulty with tummy time. I should have put that as a red flag too, because that is a red flag. Not liking that being on our tummy in that position, that is also related to feeding, believe it or not. Poor lip seal here, topping off at 2 ounces. Lots of facial tension. Now, a lot of that is caused with ties, right? And again, we see here upper lip tie, posterior tongue tie, and that uncoordinated suck, swallow, breathe pattern. So what did we do? We did some exercises. We trained them to do some suck training, some chewing hierarchies, lots of relaxation techniques, tummy time training. We were starting at, just we want to get consecutive sucks and consecutive chews. So this is probably at my baseline here. They start out at 1.5 ounce bottles at a time, 50-minute meal time. So let's see, sessions 2 to 5. So we're progressing in our suck training and our hierarchies. You can see that sucks and chews are increasing. Number of ounces are increasing. We started doing the pre-frenectomy exercises. So we didn't just jump into doing a tongue tie release. We started doing some stretches, getting the body ready. We want the best possible release. Okay, we brought our meal time down to 35 minutes. And this is before we even did anything with the ties, right? We're finally seeing some coordinated suck, swallow, breathe. Okay, now post-frenectomy, they did get the frenectomy. Okay, so now we have we're integrating our reflexes. We're sucking continuously on the bottle for the entire feed, coordinated suck, swallow, breathe, quick meal times. 5 minutes and they feel satisfied. Incredible. 20 consecutive chews. Okay, I would have been happy with 10, but amazing. So as you can see, such a difference, right? We went from struggling, we did some interventions. Aside from just doing the frenectomy, the interventions themselves showed us so much more improvement. And, after we did the frenectomy, things just got even better, right? Now, I will tell you, there's a snowball effect. So again, I kept bringing up things that happen with older kids because you can't totally separate them out. So infant feeding problems will lead to older children with feeding and oral motor issues as well. Okay, so that's what a snowball is. It might start as a little tiny snowball, but it'll grow into a bigger problem later on. Okay. Now there might be some nursing and feeding difficulties or reflux when they're a baby. But that could lead to, like I said, those, poor dentition, picky eater, texture sensitivities, those sleep issues as they get older, teeth crowding, um, you know, I mean, the list goes on. Then there's, of course, social implications like what we see now, like, okay, they can't go to birthday parties because they won't eat anything, or it's really hard to go on vacation because there's nothing there that they're going to eat, or I have to like bring, unpack, and create meals for them for the whole trip or whatever, right? So there's other implications down the line. Now, pro tip, make food fun. Right, for our older kids with aversions, it's never fun for parents or for kids. So it's about coercion for them to eat something, and that something might be overwhelming their sensory system, something they can't handle oral motor wise because they just never had the skills from infancy. So we need to take off the pressure. We don't recommend force feeding ever, right? So behavioral feeding therapy might work short term, but not long term because the kids aren't learning to like food. They're learning to do something to get something, a very quick turnaround reward system. But that's not building a love of food. That's not fixing the underlying issues that they're having, right? So, it's a balancing act. Okay. So, if you couldn't walk a tightrope, but your mom and dad said, well, you can't leave until you walk this tightrope, right? Would it make you love tightrope walking or hate it? It would make you hate it, right? So, same with food. Our intentions are good and pure. We need our kids to eat, we want them to be healthy, but forcing them is definitely going to backfire eventually. Kids ultimately can choose to not eat, and there's not a lot we can do about it. We never want kids to get to that point because that's when we talk about other things like tube feedings and hospitals and weight gain and poor focus and all the other things, right? So, you know, um, what I would recommend, right? This is the end of the presentation, but what I would recommend is you just continue to educate yourself, continue to advocate, continue to learn. Don't see the problem isolated as a my child problem. It is also affecting you, and learning to manage your emotions and learning to, you know, sort of balance the, all of the different aspects of feeding. It's not easy, but consider it like a challenge and a learning journey for you and for your child, right? So these things sometimes present themselves to us because there's something we can learn from them. So it might be learning patience. It might be, you know, learning that, you need to spend more time with them. I'm not saying that if you don't spend time with your child, that's why that this has happened. But, what am I trying to say? I'm trying to say, so the parents that come to us that want to drop their child off and pick them up a good eater are missing the bigger picture. The bigger picture is you both have things to learn from this. So spending the time to do this with your child, to overcome this challenge together as like a joint project, I suppose is what I'm saying, you will make much faster progress and have much better results than the parents that drop their child off and don't know what happens in the therapy, don't know what to do or why they're doing it, and then just say, okay, here's my copay and great. What did you do today? Had fun? Great. Let's hop in the car and get to the next thing. Okay. Instead of that, just making it a stop in your day, if you embrace it as a learning opportunity and you really, you know, make an effort to learn the whys and the hows um and also, again, we become anxious. We become part of this dynamic of the relationship between food and our kids and how that stresses us out and how that affects them, right? Learning for us to learn how to relax and have some fun with the process. I'm saying those families do much better. Their progress is faster. They're in and out of therapy faster. They leave with bigger smiles. The families that want to do the drop off, that wanted to do, we don't actually even see those families anymore because we say you have to be a part of therapy. If you don't want to, this isn't going to work for us. Like that's how we work. But because we work that way, because I've seen the difference, those families don't last very long because they don't see the results because they're not in it. They're not totally in it. So I'm trying to say, I guess, embrace this challenge. Say, what can I learn from this? How have I grown from this experience? Seeing it through that lens versus this is a problem that I'm attacking that I'm going to pay someone to fix for me. You're just not going to see the same results or be as happy. It's just you're in it for different reasons. And I'm saying the people that are in it for the learning and the growth that they see, they have much better outcomes. So I'm hoping that you take that path. I guess that's sort of what I'm saying. Now, I hope that the presentation was really helpful for you. Being a parent is always like walking a tightrope, I feel like. So I think this is a good picture to end on. But I do hope that whatever challenge you are encountering is it's going to work out and you're going to overcome it, and on the other side, you'll be able to look back and hopefully laugh and say, oh wow, look at all the amazing things that we've learned and changes we've made. And it'll just be a little blip on the screen at the end of the day. So if you found the presentation helpful, we are here for you. Please visit us at foodologyfeeding.com or on my podcast, How to Unpicky Your Picky Eater. Available on pretty much all of the podcast outlets. And, we have some of that free help, like I just said, and we also do one-to-ones and consults and parent coaching, and my book, Mealtime Mindset's available as well. Lots and lots of options to help you learn and grow and improve all of your lives. So I wish you guys all of the best, and I wish you happy and enjoyable meal times. And hopefully we'll see you again soon.